They took them. This? We'll ask for them.
Okay. Please have a seat. We are just starting now. So we have finished our glomerular lesions. Now we are starting with the tubular necrosis. Yeah, sure. There was like here. And Dr. Mohammed. This one. Okay.
They took it to the main place, but I think they had a different.
Ah. So, if we talk about the tubular injury, we first should understand the nephron. And if we see this nephron, this is glomerulus, one glomerulus. This is proximal convoluted tubule. This is loop of Henle. This is distal convoluted tubules, and these are electron ducts. So the important thing which you have to note here is the glomerulus is being supplied by the afferent artery, right? Afferent arteriole, which goes in, and then efferent arteriole goes out from the glomerulus after supplying the whole glomerulus, right? Now, this efferent arteriole then goes down and it supplies the tubule, the proximal, the distal, and the loop of the loop. After passing through the glomerulus, and then it goes down, and finally it comes out as an efferent veins after supplying the whole nephron. This is called one nephron, the whole nephron. Clear? So basically, if you see, the tubules have already a compromised type of blood supply. After having supplying the glomerulus, and then the same blood supply goes out and supply the whole nephron. And it is tightly controlled by hormones, right? Okay. So this is afferent arteriole supplying the whole glomerulus, efferent arteriole supplying the whole nephron, which is proximal distal convoluted tubules, loop of Henle, and then it goes back to the efferent vein. So what is acute tubular necrosis? It is also called acute kidney injury. Nowadays, probably this word is being used more regularly, but it is interchangeable. Sometimes we use acute tubular necrosis or acute kidney injury. Basically, it's a clinical pathological entity characterized clinically by acute diminution of the renal function and morphological evidence of tubular injury. You know, in one day, how much urine is being formed? Yes. About 2 liters, 1.5 to 2 liters. So you have 2 liters of urine per day in a normal looking kidney, right? But if this thing diminishes, means something is going on wrong. So the most important cause of acute renal failure is acute tubular necrosis and a rapid reduction of renal functions and the renal flow less than 400. So we had 2 liters normally, and it is reduced up to 400 ml. This shows that something is going wrong with the tubules. The important thing here to be noted is potentially reversible, since the tubular cells can regenerate in a given time. So this is a gift from God Almighty, that even if you have damaged the whole tubule, the regeneration process is very fast. And you regenerate the tubular epithelial cells in a very fast way. And the functions which are deteriorating, and if you have managed the patient, then the things will come back to normal. Clear? So the tubular and interstitial disease, there are 2 groups of processes which you usually see. One is ischemic and toxic tubular injury. Ischemic and toxic, which we are going to discuss now, leading to acute kidney injury and acute renal failure. And the other one is inflammatory condition of the tubules, that is the tubules and the interstitium, which is combinedly called tubule-interstitial nephritis. Microbiology people are looking for that. So we will be discussing the ischemic and toxic tubular injury. And you know that ATN accounts for 50% of the cases of acute renal failure in hospitalized patients. Those who are been hospitalized, they usually show 50% of acute tubular injury. It is reversible, as you all know, that arise in a variety of clinical settings, multiple one. The most important one is the ranging from severe trauma to acute pancreatitis. This acute pancreatitis is a very, very painful condition, right? And the patient is so painful that they go in shock. And when you are in the process of a shock, then the blood supply goes down. You know that, huh? So what happens in inadequate blood flow to the peripheral organ accompanied by marked hypotension and shock, as in severe trauma or in acute pancreatitis? This pattern of ATN is called ischemic ATN. So as the blood in a condition of shock or hypotension, the blood does not go towards kidney. Now here one question arises: what are the organs which needs blood supply? Number 1, the brain. Number 2, the heart. How much time a brain needs, or if you don't give oxygen to the brain? 5 minutes. 5 minutes, right? And how about heart? 20 to 30 minutes, right? So in a state of shock, you might have seen the patient usually faint and fell down. Now, as a doctor, what will you do? Yes, as a doctor, you will pull the leg up. Instead of asking the patient to come up, no. You will pull the leg up so that in a state of hypotension, the blood will flow from the lower extremities towards brain and heart, right? So within few minutes, as the brain gets oxygen, the patient awakes up. Don't ask him to get up. No, ask him to lie down, because it takes little time so that he will recover completely. Then comes kidney. So number 1 is brain, number 2 is heart, and number 3 is now kidney. If you don't give oxygen to the kidney, so there will be reversible and then irreversible change occur in the tubular epithelium. But as we know that this epithelium is remarkably regenerate, so everything will come back. Ischemia due to decrease in or interrupted renal flow. The diffuse involvement of intrarenal blood vessels such as microscopic polyangiitis, malignant hypertension, and microangiopathies. So this happens in the renal artery inside. And the systemic one, which is throughout the body, is hemolytic uremic syndrome, HUS, thrombotic thrombocytopenic purpura, TTP, disseminated intravascular coagulation, DIC, and decreased effective circulating blood volume, means hypovolemia. So all this thing, which is systemic, those intrarenal were 3 and the other one are these. So all of these leads to decrease in the blood flow to the kidney. Now for the toxic injury, we have drugs. There are few drugs which are nephrotoxic, some antibiotic, NSAIDs. These are nephrotoxic, some anti-cancer drugs which are nephrotoxic. So you have to be a little careful in giving them. Radio contrast dyes, like have you heard about IVP, intravenous pyelogram? Have you heard about it? What you do is
स्टूडेंट लेके जाते हैं यहाँ से वहाँ उधर लेके जाते हैं हाँ उधर इस चीज़ का नहीं है कि ये यही चलेंगे तो कैंसिल एक तो इधर होना चाहिए अभी आपने नोटिस किया मैं उसको अरेंज करूँगा टूल पे लाऊंगा यहाँ से सिक्योरिटी से पूछ के अगर आ जाता है तो मैं देखता हूँ जब आप पूरा काम किया
radio contrast dye, which is IVP. Remember, you don't give IVP to those patients whose blood and whose kidney function is not normal. So before giving the dye, what you do is you go for blood urea nitrogen and creatinine. These are the two things which confirms the renal function, right? So if both of the BUN and the creatinine is normal, then you give radio contrast dye. What you do is you give the dye intravenously, wait for 20 minutes to half an hour, and then you take the X-ray film, AUP. So in different timings. So you see that the dye is excreting from the kidney and coming down. So basically you are looking at the obstruction, right? At which level the obstruction is. For example, if there is a stone in a ureter, then the dye will not pass from through the ureter there, right? And it will show hydronephrosis of that side of the kidney. So this IVP is being used, and this IVP is basically toxic for the tubules. Myoglobulin, you all know that the muscle, this is a protein which is present in the muscle. So if there is injury to the muscle, this myoglobulin comes out from the muscle, circulate in the blood, and it is injurious to the tubules. Hemoglobin, present in RBC. As long as this hemoglobin is inside RBC, nothing wrong. But if there is hemolysis and hemoglobin is coming out, circulating in the blood, that is injurious to the tubules. Radiation, yes. If you give radiation again and again to the kidney, definitely it is injurious to the kidney. Acute tubular-interstitial nephritis, most commonly occurring as a hypersensitivity reaction to the drugs, which we usually give to the patient. And lastly, urinary obstruction, which is post-renal one by tumor. For example, any tumor which is obstructing the ureter or coming down, or prostatic hyperplasia or hypertrophy, which is not allowing the urine to come down, back pressure going on, blood clots, so-called post-renal acute renal failure. So the back pressure will go up and it will damage to the tubules. Pathogenesis, the critical event in both ischemic and nephrotoxic ATN are believed to be two important factors. Number one is tubular injury, and number two is persistent and severe disturbance in blood flow. Starting with the tubular one. The tubular epithelium are particularly sensitive to ischemia, we all know now, and are also vulnerable to toxins. So we have to take care of both of them together, including a vast charged surface of a tubular reabsorption and active transport system of ions and organic acids. Both of these things need a high metabolic rate and oxygen consumption. So you need to have blood supply to control these important two things, including vast charge surface. So it will not allow the electrolyte to go freely here and there, and active transport. So both of them needs oxygen to perform these transport and reabsorption functions. So suppose if the oxygen is coming down, there will be structural changes in the tubule, which is reversible first. So what you will see, you see cellular swelling, loss of brush border and polarity, bleeding, and cell detachment. These are all present in your topic of necrosis when you were doing POD. Dr. Oban has taken the class, right? Degeneration and necrosis. Now, after this is reversible. So if you give oxygen at this time, the tubules or epithelium will come back. Now, suppose if it is deteriorated, what will happen? A necrosis or irreversible change will occur associated with depletion of ATP, accumulation of intracellular calcium, activation of proteases, activation of 5-phospholipase, and activation of caspases. And we know this caspases will do apoptotic cell injury. So these are the irreversible injury. Even if you have irreversible injury, doesn't matter, but because we know that the tubular epithelium can regenerate fast. Okay. So the loss of cell polarity resulting in abnormal ion transport across the cell and increased sodium delivery to the distal tubules. Now the things are gone. So the sodium is going toward the distal tubules, which can cause vasoconstriction via tubulo-glomerular feedback. I'll show you the chart and you will be able to understand how this is going on. The injured cell detach from the basement membrane and cause luminal obstruction. So as the epithelium becomes either degenerative or reversible injury or irreversible injury, in both of the things, the tubule will detach from the tubules and it will come and lodge in the lumen. What it will do? It will cause obstruction. This phenomena is called discommission. Discommission means detaching from the epithelium from the basement membrane into the lumen. Okay. Now increase intratubular pressure and decrease GFR. As the cell is obstructing the lumen, the fluid will not go down. So GFR will decrease. The fluid from the damaged tubule leak into the interstitium, resulting in interstitial edema. So as it is blocked, the fluid will go up. When the fluid will go up, where it will go? In the interstitium, right? So the fluid will go in the interstitium, there will be interstitial edema and they will evoke the inflammatory change. Clear? Again, the blood supply is lost. There is injury to the tubules, right? The tubules detach from the basement membrane, comes in the center, in the lumen, and it obstructs the lumen. And as it obstructs the lumen, there is decrease in GFR. Now, once it is obstructed, back pressure increases. As the back pressure increases, it will go towards the interstitium. So there will be interstitial edema and inflammation. Now, disturbance to the blood flow. Major one is intrarenal vasoconstriction, means reduced glomerular blood flow, number one. Reduced glomerular blood flow. Reduced oxygen delivery to the functioning important tubules in the outer medulla, which is thick ascending limb and the straight segment of the proximal tubules. And the vasoconstriction pathway is renin-angiotensin system, and which has been activated by tubulo-glomerular feedback. Number one. Number two, sublethal endothelial injury, which is caused by the endothelin, which is been secreted by endothelial cells. So when the blood supply of the vessels are also compromised, endothelin is secreted. They also causes vasoconstriction. Now, decreased production of vasodilator like nitrous oxide and prostacyclin. These two elements, they are decreased. So vasoconstriction is gone. What is there with you? Only vasoconstriction. Vasodilation is gone. Only vasoconstriction is there. Now, if you see this chart, it will tell you that ischemia causes tubular injury, right? Now, this tubular injury, either it is reversible or it is irreversible. If it is reversible, there is loss of polarity initially, which causes distal sodium delivery. This distal sodium delivery increases, which causes increase in the tubulo-glomerular feedback. Now, this tubulo-glomerular feedback can cause increase in renin-angiotensin, and this renin-angiotensin will cause vasoconstriction, number one. This ischemia can cause endothelial dysfunction, damage, and this endothelial dysfunction can cause increase in endothelin. This endothelin can cause further vasoconstriction. Along with this, we have decrease in nitrous oxide and also prostacyclin, which is important for vasodilation. So vasodilation is totally blocked. So only you have vasoconstriction. On the other hand, this irreversible injury can cause necrosis and apoptosis. Both of them, the epithelium, which are detached from the basement membrane, comes in the center. It is causing blockage of the tubules. So there will be decrease, intertubular pressure increase and decrease in GFR, plus the tubular back leak, means it will go up and then enters into the interstitium. So there will be interstitial edema and inflammation. So this is a good picture. You can see that this is afferent arterial vasoconstriction, which causes decrease even in the glomerular ultrafiltration coefficient. So there is decrease in the blood flow of efferent arteriole. So it is not supplying the tubules properly. So the tubular epithelium become damaged. They are discomated, they are gathered here, and they are causing obstruction to the flow. So they decrease GFR, plus because of the obstruction, the backflow increases and they leak into the interstitium. So there will be interstitial edema. Yes.
That means, for example, we have necrosis from toxic drugs or something, then becomes ischemia.
The same thing will happen here also. Whatever toxic thing, because it is damaged the tubules, it will discommate and comes down here, and it will block the lumen and back pressure will increase, right? Okay, morphology of ischemic ATN. As we have discussed, there are two main types, ischemic and toxic. In ischemic, what will happen? It is characterized by focal tubular epithelial necrosis. Focal tubular at multiple points. So there will be necrosis, normal, necrosis, normal, necrosis, normal. So there are multiple different area of necrosis, number one, with a skip area and rupture of basement membrane, which is called tubular axis, and occlusion of tubular lumen by cast. By cast. I'll ask this question little later on. The straight portion of the proximal tubule and the ascending limb of in the renal medulla are especially vulnerable at this age. Focal lesion may also occur in the distal tubule, often in conjunction with cast. So in the distal tubule, yes, there is also skip lesion, but the cast will also be there to obstruct. Loss of proximal tubule brush borders, cell swelling and vacuolization and sloughing of the non-necrotic tubular cell into the tubular lesion can cause decrease in GFR. So what happens here? the eosinophilic hyaline cast and pigmented granular cast, particularly in the distal tubules and collecting duct. Now the question arises, what are these casts? The hyaline cast and granular cast, two casts. What are these?
Tubular.
Uh-huh.
That's the ones that.
What are these casts? Why it is normally not seen in the urine?
And the granular.
No. Anybody? Yes.
Usually we come to tubules and when Tom phosphoprotein release forms the cast.
Very nice. So basically the casts are stem-horsefall proteins, which are being, these are glycoprotein normally secreted by ascending thick limb and distal tubules. So they are normally being secreted, right? Normally. But as the urine flow is continuously there, it does not allow that cast to be accumulated there. So you don't see any cast in the urine in a normal person because about 2 liters of urine is being passed. So the kidney is always flushing. And that's the reason why this 2 liter is minimum, right? So we used to ask everybody to have more and more water because you need to have flushing of your urine. If your flushing of the urine is not adequate, then you had this problem. Clear? Understand? So this stem-horsefall protein is continuously being secreted by the ascending thick limb, and it has been regularly thrown out from the kidney. Other finding in ischemic ATN are interstitial edema and accumulation of leukocytes because of the back pressure, it is accumulating in the interstitium and inflammatory process is going on. There is also evidence of epithelial regeneration. So if you see under microscope, you will see that the tubular epithelium is being regenerated. Flattened epithelial cell with hyperchromatic nuclei. Hyperchromatic nuclei means regeneration process is going on. Also, mitotic figure are often present. Is this mitotic figure means malignancy? No. Remember, in proliferative endometrium, you see mitosis. Why? Because the endometrium is being proliferated. And for proliferation, you need mitosis. And every mitosis doesn't mean that it is malignant. At this area, when you need to have regeneration of the tubular epithelium, you will see mitosis. It doesn't mean that the kidney has become malignant. Clear? Good. Now, this is how you see in ischemic one. So this is glomerulus. There is injury, then this is normal. This is injury, this is normal. This is injury, this is normal. This is injury, this is normal. Again, this is injury, and then this blue is basically cast, which is mixed with injury and normal. Clear? Why it is not seen here? The cast is not seen here because it is not produced here. It is produced in the ascending limb and the distal convoluted tubules. And you can see this cast from here onwards, right? As the urine will start forming, it will push this cast and it will come in the urine. So if you see under microscope, what do you mean by cast? Cast means a shape. It will form a shape of a tubules. So there are two types of cast. One is hyaline cast, in which it will be just look like a tubule, or a granular cast in which you see some granules in it. Two types. And usually you see in a chronic kidney injury, right? In a later stage. Now coming to the toxic one, that was ischemic one. Now what happens in a toxic one? It is manifested by acute tubular injury, most obvious in the proximal convoluted tubule, and it is not big. means it is continuous. This is patchy, right? But that will be continuous. It will not be patchy. On histological examination, the tubular necrosis may entirely be non-specific. So we have some of the element which can cause toxic injury like mercury chloride. This injured cell may contain large acidophilic inclusion in the tubular epithelium. These cells become totally necrotic and discomated. You know, when it becomes necrotic, it will leave the basement membrane, comes in the center into the lumen, and they undergo calcification. So two important things will be noted. For example, if a patient has mercury chloride poisoning, you will see two things in the tubule. Number one is a large acidophilic inclusion, and number two, calcification, right? They are discomated and you see calcification in the cell. Means the cells are being affected by mercury chloride. The other one is carbon tetrachloride, another poison. There is accumulation of neutral lipid in the injured cell. Again, such fatty change is followed by necrosis. So in this tubular epithelium, you will see a fatty change. And in fatty change, what you actually see are lipid droplets inside the cytoplasm. So in mercury chloride, you see large acidophilic inclusions and calcification. In carbon tetrachloride, you see fatty change. So you see a lipid in the cytoplasm. And in ethylene glycol, produce marked ballooning and hydropic or vacuolar degeneration. So hydropic degeneration in the proximal convoluted tubules. So if there is ethylene glycol injury, you see ballooning degeneration or hydropic degeneration in the tubular epithelium. So we have three types of poison. In mercury chloride, you will see acidophilic large inclusion and calcification. In carbon tetrachloride, you will see fatty change. And in ethylene glycol, you will see marked ballooning or hydropic or degeneration of the tubules, right? Now, as we know that it's a continuous type of injury, so this is a continuous one. There is no patchy injury as you see in this one. So in the ischemic type, if suppose I show you this picture in your exam, and I asked you which type of injury is this? So the answer will be ischemic injury because it is intermittent one. And if I show you this one and I ask, this will be a toxic one, which will be because it is continuous one. Clear? Okay. So this is how you see grossly and microscopically. Grossly, you see this is a normal kidney, this is injured one, this is normal one, this is injured one. So you have normal and abnormal together. This is low power picture of the tubules, in which you can see that there is lot of disformation of the epithelium, and the epithelium is being accumulated in the lumen, and it is causing back pressure, right? This is a high power view of the same, and you can see discomated tubular epithelium. Plus, you see some of the cells without nuclei, means almost it is necrosed, right? Irreversible injury. And then it may shed off and come into the lumen. And in the third slide here, you can identify mitotic activity. For example, this one, this is mitosis, and this is hyperchromasia. So hyperchromatic nuclei, which shows that the regeneration of the tubular epithelium is going on, right? So you see this thing after a while of tubular epithelium. This shows that the tubular epithelium is starting regenerating itself. Now, this is a pathology. Now, what will happen after this one? A clinical course. A clinical course of ATN is highly variable, but the classic case may be divided into 3 phases. Classic one. So it does not follow the same route all the time. A classic one has an initial phase, then you have maintenance phase, and then recovery phase. In initiation phase, which lasts for 36 hours, there is a slight decline in urine output with a raised BUN. So still it is BUN which is raised. At this point, oliguria could be explained on the basis of transient decrease in the blood flow and decline GFR. So we call at this stage it is BUN. We are not calling this thing as uremia. Still it is azotemia. So the signs and symptoms are not being developed enough. In the maintenance phase, as the things goes further wrong, characterized by sustained decrease in urine output between 40 to 400 milligram per day, which is oliguria. Normally, you had to have almost 2 liters, and you are getting only 400. The salt and water overload, because the kidney is not excreting salt and water. Blood urea nitrogen rises the concentration. There will be hyperkalemia. Potassium level will be increased. Metabolic acidosis and other manifestation of uremia. So you will see the sign and symptoms of uremia now, right? Now with appropriate attention, now at this stage, if you are very vigilant and you have treated the patient properly, attention to the balance of water and blood electrolyte, including dialysis. So this is basically an emergency and you had to shift the patient for dialysis. So as you have sent for dialysis, the patient can be supported through this oliguric crisis. So you had to have dialysis almost every day. So first dialysis, second dialysis, third, and then the situation will come back to normal. So the amount hyperkalemia which is increased will go slightly down and down, right? There are many things which are really altered. For example, bicarbonate levels tremendously become down, right? Sodium, potassium is high. So there will be metabolic acidosis in the patient. In a recovery phase, it is characterized by steady increase in the urine volume that may reach up to 3 liters. Normal is 2. When excessive amount of urine is being formed because the fluid has been accumulated in the body, so it has to go out. So it has been excreted by the kidney now. The tubules are still damaged because it is not fully recovered. So large amount of water, sodium and potassium is lost in the urine. So we were having hyperkalemia. Now, because sodium and potassium is been lost, it will become hypokalemia rather than hyper, because it has been going out without any stoppage. Become a clinical problem. So in this type of patient, you had to give potassium to the patient. Otherwise, probably you can lose it. There is a peculiar increase in vulnerability to infection at this stage, right? The renal tubular function is restored and concentrating ability improves. So slowly and gradually, as I said, the tubular epithelium is regenerating frequently. So it has gained its polarity again, and it is not allowing everything to go out, which has been going initially. So it stops. That no, stop. You're not allowed to go out now. So the concentration will be improved. The blood urea, nitrogen, and creatinine level begin to return normal, which has been tremendously increased. Subtle tubular function impairment may persist for months. So it will take months. Slight proteinuria, some sodium is going out, potassium. So it will recover. It will take some time to become fully normal. But most of the patients who reach this phase eventually recover completely. So the maintenance phase, basically, the middle phase, is the most important phase. At that phase, if you have taken care of the electrolyte, everything, then you can save the patient there, right? Prognosis, the recovery is expected with nephrotoxic ATN when the toxins are not cause serious damage to other organs like liver and heart. If it is nephrotoxin and it has only damaged the kidney, not affecting the heart and liver, then probably the supportive care 95% recover completely if liver and heart is not affected. But if in shock related to sepsis, extensive burn, or other cause of multi-organ failure, means liver and heart is involved, the mortality rate can rise to more than 50%. Up to 50% of the patient with ATN do not have oliguria and instead often have increased urine volume. So as you know, as I said, that's a classical way when you have oliguric phase and the uremic, the what you call other phase. So this is in some of the patients you don't see any oliguric phase, but it's just like a normal one. They are so-called non-oliguric ATN. Now, this was all about the tubular injury or acute tubular necrosis. Something, or I will classify this thing, and I'm sure Dr. Mohabbat has taken care of acute and chronic pyelonephritis and other inflammatory conditions. So I'll just tabulate it here, and you will see her lectures. Infections, we have acute bacterial pyelonephritis or chronic pyelonephritis, including reflex nephropathy. Other infections, viruses and parasites. Toxins like drug, acute hypersensitivity, interstitial nephritis, analgesics, heavy metals, lead and cadmium, metabolic diseases like urate nephropathy, nephrocalcinosis or hypercalcemic nephropathy. When the blood calcium level becomes so high, they go and accumulate in the kidney. That is called nephrocalcinosis. Acute phosphate nephropathy, when phosphate level is increased, it is accumulated in the kidney. Hypokalemic nephropathy, oxalate nephropathy. We have physical factor like chronic urinary tract obstruction. Obstruction can be stone or anything or any tumor which is obstructing the way. Neoplasia like multiple myeloma, and you see light chain cast nephropathy, and this condition is also called myeloma kidney, right? Then we have immunological disorder like transplant rejection, Sjogren's syndrome, and sarcoidosis. Some vascular diseases can also cause this thing, and miscellaneous like Balkan's nephropathy, nephronophthisis, medullary cystic disease complex. We will discuss this thing in a cystic disease of the kidney, and idiopathic interstitial nephritis. So this all tubular interstitial nephritis can lead to injury to the tubules. So this was all about the tubular injury. Please be ready for your attendance. Any question?